I would like to remind you about the population of women, not only who are in the childbearing potential, but also a little bit more mature, where everybody forgets that actually they might also be HIV infected. So our patient has had cervical cancer in 2005 when she was 55. Then after that, she suffered from myocardial infarction, which is also in line with the age. She has coronary artery bypass graft implanted with fully blown cardiosurgical intervention. And then actually in March 2012, she has had bronchitis and oral candidiasis, which was all reflected in the medical history. And finally, she was diagnosed with HIV. She was diagnosed with HIV not because somebody thought that she might be HIV infected, but actually because her 10-year younger partner has had tuberculosis. So she was retrospectively actually tested when she could have been tested, being 55 years of age, with cervical cancer as the AIDS already there. So then actually we have had a patient with very low CD4 count, with 74 cells at the beginning only, with huge HIV viral load, 613,000 copies, and it was subtype D. She's Polish of origin, she's white, she has never left Poland, and I will comment on the subtype D in a second part of this presentation, actually, just to give you a little bit of a background. Baseline, there was no drug-resistant mutation, neither to protease, RT, and integrase. We did it retrospectively from the frozen sample because it was not available at the time of analysis, at least for the integrase. And also the tropism was okay. It was CCR5 tropism. She was delta-delta negative and HLA B5701 negative. And actually what happened, the lady, knowing that she is HIV positive, that her CD4 count is very low, she said, I do not want to be treated. I declined the treatment. Her partner was in the hospital at the time, and she didn't want to come to the clinics. So, and this situation continued like this for 6 months. When we have finally admitted her, because there was no other option, because actually she couldn't breathe, she had dyspnea, and there was PCP pneumonia, very severe, which was in the end complicated by pneumothorax, and it ended in thoracosurgery. Then in the course of this very long hospitalization, it was 6 months in the hospital, we have had diagnosis of MAC, which with a treatment of clarithromycin, ethambutol, micobutin, which is rifabutin, then CMV retinitis, vitrectomy, so also ganciclovir, followed by valganciclovir, clostridium as a complication of a very long hospitalization, recurrent urinary tract infection complicated with sepsis, oral candidiasis, and it was all like this during very long time. The wasting was there, and also just to add, there was an ulceration on the left breast, which the patient said, okay, I'm so ill, do not touch it. I do not want any biopsy for that. I do not want anything done with it. Just if I will survive it, which we thought she will never do, we will maybe deal with that. And it's just another story which continues up to today. So what happened virologically? And if you would just look at the scale, this is a log scale for HIV RNA on the right. So you could see that she actually never was virologically suppressed from the outset. The first CD4 count is there. This is with 74, then she dropped to 5 on admittance. And then viral load dropped as we started the HIV treatment. But then when we discharged her after 6 months, it rose again. And you could see that there is a resistance to integrase. And what is interesting, we have done it twice. We didn't have it readily available, so we have just had both samples, both results coming back at the same time at different time points. So the first time point, you could see 155H mutation and she was on raltegravir at the time, single dose, because she didn't receive rifampicin, she received rifabutin. And the second one is 148 and 140. So she basically switched the pathways while being on the treatment. So when we received this delayed report, we changed the treatment, and the treatment was changed to dolutegravir. But just to remind you, these two pathways that we are talking about. It was well discussed today, and this is what would clinicians see: high level of raltegravir resistance with intermediate dolutegravir and necessity to double dose of dolutegravir, and in the second case very similar, except for the fact that low level dolutegravir would be noted in Stanford database. Okay, so we have switched the treatment to Truvada and dolutegravir BID, and we didn't get very good result. This is what we got. This is 300,000 copies still. But the patient refused to change the treatment at the time, and you could see that the mutation accumulated as the case continued. The virus was R5 tropic, and in the end, we managed to change the treatment, and I will show it to you just in a few moments. So these are the issues that we face in such a lady, in such a person. Firstly, she is highly inconsistent in the treatment. She doesn't want to be treated. She doesn't accept the disease. She requires treatment for other infections. She requires hypertensive and dyslipidemic treatment, obviously, because of cardiac disease. There is also potential breast cancer, which we are not sure. There is just a lesion on the breast. She is depressive, and there is a switch of pathways in the integrase. So most of us focus on young gay people, and this is the most targeted population. But also there is this population of women, especially in Central Europe and very importantly in the Eastern Europe, who are stigmatized, who will be marginalized, and where the funding and insurance access and immigration will be of a very important issue. This lady is insured, so there is no problem with it. She is Caucasian, she is Polish, so full access to any treatment that she actually accepts and allows us to do will be there. But also this population of 50+ women, where you could see that actually oncologists never tested for HIV, that cardiologists never thought of HIV. There was a slight leukopenia at the time of CABG, which we could see, but nobody actually even thought of HIV test. And we have a few of very similar 50+ diagnosed women, and there is a huge delay in diagnosis, at least 2 years, and there is much higher likelihood of an oncological diagnostic for lymph node enlargement than for simple HIV test. This is what our experience shows us. And also this is the population which will have a frailty problem. So she will be aging, she will have inflammaging, she will have higher risk of cardiovascular disease. Actually, this is the highest possible anyway, because she's after CABG, very low CD4 count, so the very high risk of death. So we have multifaceted issue, not only because of delayed diagnosis, comorbidities, but also related to these acceptance issues, poor adherence, which led to resistance development, and eventually in the increase in the bill burden, lower acceptance, so there is a vicious circle here as well, and aging and frailty. And just to comment on the subtype B, which I have shown you, this is something that we have in the northwestern Poland, and this is something which is only here. We have more than 50 cases of Caucasian people never traveling who got infected by the heterosexual route. This is an infection which originates from Uganda and was probably imported by the sailors, but the characteristic thing about it is that it's mostly women. These are women late diagnosed with AIDS a diagnosis very commonly heterosexually infected with no history of injection drug use ever. So this is something that we see regionally, and actually this is just the cluster of these women, and just one of these, just of interest here is 1 man and 4 women who got infected from the same source. He didn't know that he was HIV positive. And this import of subtype B was to our country by travelers, not immigrants, sailors, and this is all ongoing at the moment. This is immigration rather than, immigration not related to immigration, but also non-B subtypes are occurring. And in the end, we switched the lady to darunavir with maraviroc, with atravirine, and we got very nice virologic suppression until a very recent study where we still got visible drug resistance to integrase, no other drug resistance mutation, just a polymorphic K70N, R5 tropic virus. And the question, what to do now? There is 1,430 copies of the virus with quite good CD4 count, and whether to continue, whether to switch, change something in the life of the patient. So this is also the question for discussion from this case. So thank you very much.